All right, thank you very much, everybody, for joining us today, and welcome to today's webinar on the role of AI in the future of health and mental health. I'm just going to begin with an acknowledgement of country. So we acknowledge that we are hosting this webinar from the lands of the Wurundjeri people of the Kulin Nation. We also acknowledge the traditional custodians of the various lands on which you all work today and the Aboriginal and Torres Strait Islander people participating in this webinar. We pay our respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters. I'm just going to start with a few quick introductions. So my name is Diane Sivasubramaniam. I'm an associate professor and I'm the chair of the Department of Psychological Sciences at Swinburne. And on the call today, we also have Sam Wilson. Sam is an associate professor in the School of Business, Law and Entrepreneurship at Swinburne. And together, Sam and I co-lead the Public Interest Technology Program in Swinburne's Social Innovation Research Institute. And Sam and I co-lead the Sam and I collaborate with Lawrie Zion, who is the theme lead for social change and equity at Trobe University, to convene the Technology by Society Forum. So the Technology by Society Forum is a joint initiative of Swinburne and La Trobe universities. And the aim of this forum is to provide a space for engagement between STEM academics and HASS academics with an interest in the design and development and application of public interest technology. So our goal is to stimulate multidisciplinary collaborations to address complex social challenges. And with each forum, with each event that we put on, like today's webinar, we are looking to support opportunities for research and for leadership and for social innovation by researchers at Swinburne and at La Trobe and our partners. So today's webinar is the 5th event of the Technology by Society Forum. And I'm very excited about this event because it addresses such an important topic. We're going to talk about developments in this field that are imminent and that are really thought-provoking. Typically, if we think about the way that AI is developing and is being developed across industries, we tend to think of AI as dealing with really simple tasks, repetitive tasks, tasks that maybe don't need to be handled by a human. So in other words, the role of AI as we think about it is to complement our more human work or to support our more human work. But is that really the role that AI is actually playing or will play in the health and the mental health domains? So today you're going to hear from 4 speakers who will present their research on the psychology underpinning the implementation of AI in healthcare. And our speakers are asking questions like, how well can AI diagnose psychological disorders or assess suicide risk? How do health professionals perceive the role of AI in their work? Do the public trust AI in the care of vulnerable patients? And to give you a sense of how this will run today, we're going to have very short presentations. So we'll just hear from our speakers. Each person will speak for 5 minutes. They're just going to give you a taste of what they're doing. Then we're going to have a 15-minute panel discussion where Lawrie Zion will facilitate a discussion among our 4 panelists to expand a bit on their ideas and their work and to explore connections between them. And then we will have 10 minutes for audience Q&A before we wrap up. So just a little housekeeping before I start to call on our speakers. So during today's webinar, we do invite you to comment and ask questions. Please feel free to pop your questions in the chat anytime, or you can use the Q&A function on the Zoom. But we're going to hold the questions till the end. We'll pose your questions to our speakers during our audience Q&A time. You can also, during the Q&A, use the raise hand button to verbally ask your question. Note also that this webinar is being recorded and it may be published on our website and on social media pages, or it may be published on the social media pages of our partners. So if you don't want to appear in the recording during the Q&A, please email our Research Events Officer, Paul Lavey, at that email address on the slide. And we'll distribute this recording to all of you shortly after the session. So without further ado, I want to move aside and make way for our speakers. So our first speaker is Chris Ludlow. And Chris is a lecturer in the Department of Psychological Sciences at Swinburne University. He's a clinical psychologist with over 15 years of experience, specialising in child and adolescent mental health. And Chris serves as the Deputy Director of the Swinburne Psychology Clinic. Let me just get your slides up for you, Chris. Here we go. And Chris, please go right ahead.
Okay, okay, fantastic. Thank you. So I'm talking about investigating the capability of large language models to identify causal relations in psychiatric case studies today and the implications for psychological formulations. So the first part of this might be just a little bit abstract, but I'm going to demonstrate the principles with some practical examples before the presentation is over. So psychological formulation, for those who don't know, within the field of mental health, there's diagnoses, but clinicians also have clinical hypotheses or clinical theories about what's going on for the patient. And so those clinical theories and hypotheses are written down in a narrative form. And so I'm interested in investigating or finding ways of applying research to those clinical hypotheses. And so large language models, things like ChatGPT, and natural language processing have the capability of analyzing that data, extracting that information, the causal information that's in that narrative, and representing it in a machine-readable format. So that's essentially what I'm looking at in my presentation. So we can go to the next slide. And that just gives us a bit of an overview of what I said there. Defining psychological formulation. So these are the clinical hypotheses about the case, and that the main research aims that I've been investigating, trying to find a way of not just converting this information into a machine readable format, but validating and actually showing that the relationships and the causal factors and the symptoms that ChatGPT and large language models identify are actually aligned or similar to that of a clinician's. So we go to the next slide. I'll give you an example of what that actually looks like in practice. So this is an example of a psychological formulation or the clinical hypotheses. This is a standard practice in mental health. All clinicians write these down. It's a requirement of the work that we do. I won't read this out, but this is a very brief example of what would be in a health record, which is hypothesizing for an individual, a young person with auditory hallucinations, that there's a number of key factors that have played a role in causing their psychiatric symptoms. Here we say family history, cannabis use, and anxiety. So if we go to the next slide, what I'm doing in my research is I give ChatGPT a prompt. And what's really wonderful about ChatGPT is not only is it good at natural language processing, it's also good at computer coding as well. So essentially, we are converting the clinical hypotheses that are in the health record into computer code. And once that information is in computer code, it means we can apply statistical and mathematical analyses to these clinical hypotheses. So we go to the next slide. You can see an example of what this looks like for the case that I gave of the auditory hallucinations. You can see, if you look at the code on the left, the causal factors have, or the symptoms have arrows, or causal factors are pointing to symptoms with the use of an arrow in the code. And that can also be represented visually, as you can see on the right. So we go to the next slide. What I've been, that doesn't show up for some reason, which is a sad, but that's fine. It's not a problem. But what you would be seeing, if we could see it, is that I've developed two methods for just demonstrating that there is alignment between what ChatGPT is identifying and what the clinician is identifying. So the two methods, one looks at the similarity in connections, using ideas that come from set theory. People will be familiar with, Venn diagrams and things of that nature. So there are similarity metrics that can be used to examine the similarity and connections, because we're representing the formulations, not just in computer code, but as a graph with nodes and connections, or nodes and edges. And then the second method that's being used is looking at the similarity. If we go to the next slide, the similarity in the symptoms and the causal factors. And in the research, I've used a range of metrics for looking at whether or not this is a useful strategy for classifying the symptoms and nodes, for essentially demonstrating that there is alignment and agreement between a clinician and what the AI is identifying. So if we go to the last slide, for some reason the image showed up in that last slide. I don't know why, but anyway. But essentially these are tentative results, but they do show that there is correspondence between the clinician and the AI in being able to identify causal relationships within the clinical hypotheses that are routinely documented within clinical health records. This research has been conducted on simulated data, and so future research needs to look at more complex cases using real patient information.
Thank you, Chris. That's wonderful. Thank you for sticking to time as well. Our next speaker is Ravi Iyer. So I'm just going to stop sharing my screen so you can put your slides up, Ravi. Ravi Iyer is a senior research fellow in the Centre for Mental Health and Brain Sciences and a biostatistician consulting to the Magnet National Network of Clinical Trials. Ravi is also a counsellor in private practice working with complex trauma. Take it away, Ravi.
Thank you, everyone. I'm just trying to get my PowerPoint to play nicely. Here we go. Every year, 1,250 people across Australia lose their lives on Australian roads. But it might surprise you to know that almost 3 times as many people lose their lives by suicide. This is a figure that has been remaining fairly constant over the last 2 to 3 decades. So something clearly needs to change. At Swinburne, we're approaching this problem from a very different perspective. In fact, 4 years ago, we partnered with a national telephone helpline where we obtained a very large collection of inbound call recordings of members of the general public who have telephoned in to discuss a range of issues, many of them relevant to suicide risk. What we did was convert or look very closely at small segments of speakers' sound waves and focus in very closely on little windows of time. In fact, as small as 40 milliseconds of a sound wave. And in those little tiny windows, we were able to extract 65 different biomarkers. And what we found were some very interesting things when we applied a machine learning algorithm, a form of artificial intelligence, to some of those 65 different speech markers. For instance, we found that as people are at greater risk of suicide, they speak with considerably more physiological effort. They have to propel the air out of their lungs with a lot more forcefulness. We also found that people on average speak more loudly, with higher frequencies and with greater roughness of speaking voice. In fact, our algorithmic approach was able to predict suicide risk in about 500 recordings to above 98%. And in fact, we took this same algorithmic approach by looking at small windows of speech, and we applied it to a second question of how distressed people are. And we also had a tremendous amount of success here, predicting the level of distress to a level of accuracy above 95%. We're now working in our small lab with a couple of PhD students to develop a holistic way of bringing this real-time predictive capacity around suicide risk back to callers. So back to counsellors rather, working on telephone helplines. So the counsellors are instrumented with the tools, the early warning system, to allow them to ask important questions of callers when callers are at risk of suicide. We have a PhD student, Ravini Sanjiva, who is developing a chatbot capable of collecting important demographics and obtaining a speech sample prior to the counsellor talking to the caller. The suicide algorithm processes that short sample of speech. And then another PhD student, Joyce Gu, is developing a clinician decision support system that relays important infographics back to counsellors so that they have a real-time alert system about where callers are at. Thank you very much.
Amazing, Ravi. Thank you very much. And our third speaker is Taylor Gogan. So Taylor, I'll just get you to share your slides. Taylor is a lecturer in the Department of Psychological Sciences. Taylor's early research focused on how we recognise and identify faces. He's currently working on a range of forensic projects around police use of new technologies, such as facial recognition algorithms, and also on the use of AI in various professions, such as in healthcare domains. Please go ahead, Taylor.
Thanks for the introduction, Diane. So I'll be talking about a few different projects that I'm involved with that all centre around assessing the current state of AI readiness in nursing around Australia. So as you can see, there's quite a few people involved in these projects. Half of us have more of a psychology background like myself. Some of us are more from the nursing field. But I also just wanted to point out that these projects are actually led by Dr. Julian Oldmeadow, even though I'm just here presenting it today. All right, so similar to pretty much every other profession under the sun, nursing is expected to be substantially impacted by the use of AI technologies. And it's been promised to enhance efficiencies in different domains. So things like streamlining administrative tasks, helping patient monitoring, and even aiding in clinical decision-making. So for instance, nurses might use this technology for things like working out whether a patient is ready to be discharged from hospital or whether someone's at risk of developing complications as part of treatment, or even with older adults if they're at risk of like predicting the likelihood of falling and things like that. So it can give them a lot of information that can actually help with their day-to-day jobs. But obviously when we develop a technology, we can't just drop it into a workplace and assume it will fix all of our problems. We need to make sure that the people who are using the technology actually have the necessary skills to use it effectively. So across a few different projects, we're interested in assessing the state of AI readiness in nursing across Australia. We're hoping to identify gaps in knowledge and understanding, but also identify barriers that might impact their readiness or even willingness to use AI. And the end goal with this is to try and use this information to inform the development of future courses in nursing to make sure that the next generation nurses actually are trained to use this technology properly. And so we're hoping to look at this from a few different angles. We're collecting data from nurses who are currently working, nursing students, and nursing educators. So the first project, we're looking at nurses who are working in critical care units. And this is actually the population I'm most interested in because by and large, most of these nurses, they were trained well before the development of AI, or rather the explosion of AI. And yeah, so we're curious to see what their perceptions are. Do they welcome the use of these technologies? Do they see them as a threat? Do they feel like they're able to actually use them effectively? And so we're currently conducting some semi-structured interviews to try and unpack this a bit more. We're going to use data from those interviews to help inform some follow-up surveys as well. In another project, we're looking at nursing students in their final year of study. So in other words, the people who are just about to enter the workforce to see to what extent have they been trained about or been rather taught about these technologies, but also about their sense of career optimism. Does the integration of AI healthcare technologies make them more optimistic about the future, or does it make them feel a bit disillusioned or disenchanted? Does it not affect them at all? And so the last group we're interested in is nursing educators. So rather the people who are training the nurses. We want to know to what extent are they already teaching nurses about these technologies, or sorry, students about these technologies? And are they planning to in the future? Do they feel capable of actually conveying this knowledge? Again, given that they themselves will be not taught it when they were students. And so the end goal here is really just to see what the current state of AI readiness is in nursing and where there might be potential gaps in understanding. And yeah, and essentially once we know that, we can help develop future training courses to teach nurses to use these technologies effectively. Right, I might hand over to Alona.
Thank you, Taylor. And Alona, if you can pop your slides up. Alona McNeil is a lecturer in psychology at Swinburne. She's a social psychologist with over 15 years of experience, specialising in the role of self-regulatory processes in our decision-making and behaviour. So please go ahead, Alona.
Thanks, Diane. So my name is Ilona McNeil, and together with a few colleagues, I conduct research on trust in AI in the context of health. So what is trust? Well, trust is defined as the willingness of a party to be vulnerable to the actions of another party based on the expectation that the other will perform a particular action that is important to the truster, irrespective of our ability to monitor or control that other party. So this picture of the falling person hoping that they'll be caught is a really good example of a trust exercise. And furthermore, trustworthiness is determined by 3 attributes of the trustee, namely their ability or the skills and competence of the trustee. So is this person strong enough to catch me? The benevolence or the motives of the trustee. So is this person motivated to prevent me from hitting the ground? And integrity or the adherence to shared principles and values. So does this person perhaps only feel the need to catch a subset of people, a principle I might not agree with? Now, these 3 attributes have been translated into attributes for automated processes and AI by Lee and C, who define them as performance, purpose, and process. So why is trust in healthcare-related use of AI so important? Well, research has shown that if trust levels are lower, people are less likely to use health support that incorporates AI, and also less likely to approve of their doctors using such support. And also, where support is being used, AI support, lower trust will result in reduced acceptance of the advice or diagnoses that are made with the involvement of AI, and reduced willingness to start and adhere to treatment. So our team is exploring different ways to grow trust in AI, including the use of procedural justice, human oversight, the perceived purpose of the AI system, as well as how human-like the AI is perceived to be, the personal safety involved in using AI, and data privacy. And I'll briefly expand on some of these today. So firstly, in an experimental scenario study led by myself, we presented participants with a primary care setting where they're being referred to an AI-based diagnostic facility for the potential diagnosis of leukemia. And we manipulated 2 components. Firstly, procedural justice. So the GP either doesn't mention the AI, or the GP mentions AI but leaves it at that. Then there's a condition in which the GP mentions AI and asks the person to voice their thoughts on the being referred to an AI-based facility. And then finally, a condition in which the GP mentions the AI and then allows the person to make a choice between going to the AI-based facility or a traditional non-AI diagnostic facility. We also manipulated AI justification, so giving people different reasons or no reason at all for the use of AI in diagnostics, but that had no effect. However, being given a choice led to higher trust in the GP, both in terms of their ability and their perceived benevolence than any of the other conditions, and higher trust in the GP, particularly in terms of their perceived benevolence, led to higher trust in the diagnosis, higher trust in the treatment advice, and greater willingness to start treatment. In a similar scenario study led by Dr. James Williams, the following 2 components were manipulated: a human in the loop, so were the AI results reviewed by a human doctor or not, and AI explanation. Now, in this case, the trust in the doctor, the AI, and the diagnosis were all significantly higher when there was still a human in the loop. AI explanation did not result in any differences in this case. Now, finally, a project led by Dr. Brad Elphinston, which focused on genomic biobanks rather than AI, has provided us with several key insights that will need to be taken into account in the use of AI in health as well. Firstly, people show concerns about the use of their data. And this is particularly the case where there is commercial involvement. And in this case, participants are concerned about the purpose element of trust. So what will their data be used for? And similar concerns could be expected in the use of AI data. Related to this, people show a clear preference for the involvement of public institutions, such as universities and hospitals. And having data repositories managed by these types of institutions creates a greater tolerance for commercial involvement. Another finding was that involvement from overseas entities reduces trust, and this is something that will also need exploring in the context of AI. So all in all, it is clear that a multitude of factors need to be taken into account when it comes to trust in AI, and that we shouldn't just focus on the way AI is performing, but also on the way it is being delivered to its potential users. Thanks, that's all from me.
Great, and thanks everyone for really fascinating presentations. Before I ask a couple of questions myself, I'm just going to remind people who are attending online, which is all of us, of course, to just put questions in chat, and we'll start to get to those in a few minutes' time. Ilona, I might just start with a question to you about the research you're doing. So if I understand it correctly, there's no situation where the doctor's not part of the diagnosis and the dissemination of results that might have been used with the assistance of AI. Is that correct?
In the scenario studies we've been using, there was one led by James that looked at actually the advice was generated by AI and there was no human oversight. And there are studies being run like that. Now, even though in Australia that's not currently the case, that it is expected that that will or might be the case in the near future, that some tasks that are currently being delivered by healthcare professionals will actually be directly delivered by AI systems.
And are you aware of particular conditions that are more or less likely to be subject to patient trust? Like, does it depend on whether it's a disease with a with a terminal prognosis, something like someone who's got a cataract, using AI to determine what's going on there, but it's not life-threatening?
The effects are definitely stronger. There has been research in that. The effects are definitely stronger for more serious impact illnesses, but they do still exist. Like there's not always a high enough level of trust as well with the lower impact diseases. It's just that it's definitely amplified by the seriousness of the condition.
Yeah, I might this question for you, and also for Taylor, because sorry, just got a croaky voice today. I don't need AI to tell me what's going on there, but really about the kind of the way that the medical profession are trained in the use of AI, not just for them to be able to use it for diagnostic purposes, but also for the explainability of what's happening to patients. And Taylor, do you feel that nurses are actually getting this kind of education in the courses they're doing now? Is there a gap between training and what's actually happening in practice?
Well, I mean, that's one thing we're interested in these studies. So we haven't collected any data yet, but my gut feeling is probably not. And I think something you alluded to is the fact it's actually really hard to explain how these AI systems work anyway. So it's even hard to know what that would look like. And that usually the explanations that make sense, probably like they're not overly accurate, if that makes sense, because for a really accurate explanation of how it functions is so complex that it's almost devoid of meaning in a sense. So I'm always curious to see how they're going to go about teaching nurses about these things, because you're right, they need to be able to explain it to some extent to patients, that you can't just say, we've got this, mystery technology. They need to tell them something about it. So I'm curious to see what they actually learn, or what they're going to teach them. So,
yeah. Ilona, did you want to add to that in the case of doctors?
Yes, so I do know that in the case of GPs, for example, many GPs they don't know whether the diagnostic facilities that they sent their patients to are using AI and to what extent. So that's currently obviously a great barrier in having open communications with their patients about what is being used, given that they don't actually know themselves. within the field of radiology, where AI is at the most at the forefront in being used, they are actually looking at communicating at clinics or radiology clinics and different ways about communicating about the use of AI there and how that's influencing patient trust. But there's still definitely some gaps that need to be filled. Yeah, particularly when it comes to our primary care providers and making sure that they know what to actually communicate and how to best communicate it.
Yeah, I think I wasn't suggesting, Taylor, that nurses should be able to explain the,
No, of course,
coding
yeah.
and all of that better, but more in the sense of, well, this is, what we're doing now is a collaboration of what we're getting through the tech, as well as what we know, something obviously expressed better than that in a different kind of context, but where in a sense they're able to communicate the role of AI, I suppose, is what I was really asking about. Yeah.
Yeah, and I think, and a part of that comes into the fact that they're probably trying to work out what that role is themselves, and then in addition to actually communicating that to potential patients too, because like for instance, one thing I'm really curious about is what do they do if an AI gives them information that actually contradicts their own judgment? So if an AI tells them that, oh, you should discharge a patient, they're ready to leave the hospital, but they feel like the patient needs to stay under observation, I'm really curious, like, how do they reconcile that? Like, what do they blindly trust the AI? Do they disregard it? And so I get the sense that they're not entirely sure about their role themselves, and then let alone conveying that to patients.
Yeah. I think we'll return to this theme again. I want to go to Ravi's study, which is just fascinating. And Ravi, I guess, again, being a layperson here and looking at what's been understood through the analysis of very, very short bits of conversational sound or voice, how much does this actually advance what people who are on these lifelines would be able to determine from the kinds of conversations they're having without this kind of assistance from technology? In other words, what's the difference between using this and not using this?
Lawrie, you picked up on one of the many questions that seem to be flowing in, which is
right.
really
I'm
really
not
great
plagiarizing
question.
others. I'm just
the response I gave was that we actually don't know, because the research in telephone helplines is so scarce that, especially around clinician wisdom, as I alluded to, there is one study coming out of Scandinavia in the last few years where clinician wisdom amongst telephone nursing staff was actually surprisingly accurate. We probably think that the use case for this technology, this biomarker speech technology, is more appropriate for new counsellors as a training tool, but possibly also as a validation tool for people with substantially more experience and a well-honed clinician wisdom.
Yeah, I'm wondering what also in what's been picked up so far in research for this, what is the time frame when it's saying 98%,
Yes.
fit into the category if they're going to do it? Yeah. What's the time frame from when they're actually making the call to when that action might occur? I know I wouldn't know all the answers to this, but roughly, are we talking about something that might happen in a few weeks, or is it so critical that an intervention is required straight away?
We can't really answer that question, largely because what happens after that moment in time when our technology is applied is anyone's guess. A lot of people de-escalate, a lot of people escalate even further. It might happen straight after the call, but suicide might be a possibility 2 weeks later. We don't know. The beauty of this technology, though, is that it paints a very accurate picture in the present moment that the speaker is speaking. So it instruments the counsellor to do something important, to ask very important questions of the caller and address the risk, that the elephant that's in the room in that present moment.
Wow. And what is the likely rollout of this kind of technology, presuming your leadership in this area and others? I mean, how much needs to take place in research in an area where obviously you're dealing with desperate situations a lot before it can be approved and put into the field?
Yeah, such a such a tension between international ethics at the moment.
Yeah.
There's huge movements underway internationally in the EU and also in America around transparency and explainability of technologies like this. It's not easy. However, we have prototypes that work, that have substantial evidence of their efficacy. So now we're looking for different opportunities to bring this into a live context.
Wow, fascinating stuff. All right, I've got a question for Chris before we go to questions from people attending today. And Chris, the AI alignments that seem to be, forensically possible here are really impressive. Are there some conditions that you're seeing in your research that seem in mental health areas to be easier to map or easier to diagnose with the assistance of artificial intelligence than others?
Look, not easier per se, but I think that what a lot of people in the general public probably don't realize is that because there's so much focus on psychiatric diagnoses, is that the what we call this formulation, this case formulation, which is the clinician's hypothesis about how everything kind of fits together, is probably just as important, if not more important, within the field of mental health. But given the fact that it is it's a set of ideas, it's a narrative, it is an area that hasn't been very well researched given its subjective nature. So I guess the application of AI to investigating these clinical hypotheses, it's still very much an open question. I don't think we really know. It might struggle with more complex cases. It's still something that still needs to be investigated.
Yeah. I'm going to start going to questions that are coming in as well now. At the risk of me just ventriloquizing some people out there without realizing it. And there's a question from my colleague at La Trobe, Piers Gooding, for Ravi, which is what you think about claims that attempts to find oral biomarkers for mental disorder or suicide risk is a kind of neophrenology, which is a pseudoscientific measurement of skull shape. Some critics like Beth Semmel at Princeton have said precisely this. And she also raises concerns that this technology is often presented as objective, conveyed in this term digital biomarker, when in fact there are multiple subjective points involved in labeling and presenting data. So there's a second question, but that's a meaty one. We might start with that.
What a wonderful question. I guess putting my biostatistician hat on for a moment, I think there are curious things that happen when we average out across a range of recordings, and what might be unique for one person becomes less unique when we're looking at hundreds of people. And what we're talking about in terms of raised voices and higher frequencies and greater physiological effort is what we're finding across a broad cross-section of the public of callers who are utilizing telephone services. We're less able to say what uniquely identifies each person who is phoning in. That would require substantially more work, and that's certainly what we're oriented towards. Analogous to phrenology, I'm not quite sure about that. Distinctly objective, probably not quite at that point yet either. Perhaps somewhere in between would be my diplomatic response to that question, I think.
And a follow-up from Piers, which she's asked to have put to you if no one else asks. No one else has asked, as far as I know. Relating to your legal background, Ravi, can you talk a bit about how you or your partner orgs get consent from callers to use their crisis calls?
Yes, another ethical conundrum. So we were successful in obtaining a consent waiver for our research project. Most of the recordings, in fact, all the recordings were historical recordings from the previous 6 months. So we were able to argue that the benefits from our algorithmic development, i.e. attempting to save lives and reduce that number of 3,000 people a year right down, far outweighed any risks posed to individual callers contacting the service. We also cited international evidence that supports the use of call recordings for algorithmic work in this area.
Great. A related question, which you might have touched on a bit, but this is to everyone really, from Alexandra, about can each speaker provide, and now this has jumped as I'm reading it, sorry, I've got it. Can each speaker provide any insights into what it might take to provide comfort or reassurance to patients or parents of kids, whether helplines or in hospitals, I guess, that the tech might actually help the human being who's trying to help them? In other words, how do you do a sales pitch for the value of this to people who might already be so distressed that they're not really able to take this in or not able to provide the kind of consent that's required for this to go forward? So I'll let anyone pick this up, because I think it probably is a question across a lot of the work that you're doing collectively, I guess. Does anyone want to have a go at this one?
I'm very happy to jump in there. As
Okay.
I responded and feeding into Alona's fabulous work there, trust is absolutely crucial in this area. In fact, in terms of speech biomarker work, if prediction falls below 80%, there's just no point in revealing that to counsellors or callers. First point. The second is explainability. What we need to get over the line is that it is not smoke and mirrors. AI, it can be explainable. We can talk about these things in plain language statements. And I think that carries technology like this across the line for the majority of people. For a minority, it'll always be a hard sell.
Yeah, even though I guess a lot of tech is embedded into our lives without us realizing it. We don't have to sign consent forms to get a playlist from Spotify, but obviously people are subliminally using text unconsciously, not texts, unconsciously or semi-consciously as well. Does anyone else want to comment on that before I go to a question for Alona? Jump in if you do from the panel.
I'll just say quickly, I mean, a lot of these innovations are still in that testing phase, and just like with all good engineering, there's a lot of safety work that goes into developing technology before it's actually released or unleashed onto the general public. So, I mean, some of these things might still be quite a number of years away. If you look at the software that's used within most hospitals and health services, you'll see it takes many, many years before technology is actually ready to be released. That joke is a lot of software in the hospital is very old.
Yeah. Sorry.
I just had, I guess, one thing to add is that we and other researchers have been looking into different ways to, I guess, make the receivers of AI-based advice more at ease with the use of AI. And in general, in the earlier days, so looking at research, it's very rapidly evolving, and obviously the use of AI it's increasing by the day. So a few years ago, manipulations, like experimental manipulations is what we use the term for, but like basically telling people about the accuracy levels of AI was really important in increasing their trust. But what we are finding increasingly, like in our recent studies, is that actually justifying the use of AI in itself doesn't really increase the trust. It's more that people might be worried into in not so much the general accuracy, but the accuracy for them as a person and the implications for them as a person. And that sort of feeds into the potential for biases in the software. What are the motives of the people who program the software? What is their data being used for, etc.? So I think that accuracy level is something that obviously it needs to be at a high enough level before AI is being implemented. And out of all the concerns people have with AI, that seems to be one that is starting to fall a little bit to a lower level compared to some of the other concerns that they do have. Because people think, okay, they more and more people are using ChatGPT, they're using AI in their own daily lives, not necessarily always, that accurate, but they're becoming more comfortable with AI on a daily basis and use of it on a daily basis. But it's these other concerns that definitely still need to be addressed.
So you're partly answering a question put up by Oren Sivia, which was, do you investigate whether trust actually increases if patients know that the AI tools were tested thoroughly in the first place? Are patients concerned about bugs in the software system? So, yeah. So
I think it is definitely something that will still play a role. I'm not saying that is something that people won't be concerned about at all, but I think it really ties into that question of what are the biases that are present in AI, and will it be equally accurate for me as it will be for other people in the population? And I guess but on the other hand, like AI is an interesting one in the sense that it does still have these general biases, but it also has, I guess it has a promise, like it has the potential for us to program it in ways to potentially overcome biases that humans have, because healthcare providers aren't exempt of having their own biases, right? And it's much like, is it harder to change the bias of your healthcare provider than it is to change bias in AI as soon as we know what kind of data to use for it? And that's an interesting question where maybe moving forward, AI actually has some potentials of overcoming these biases in a better, more effective way than actually trying to train healthcare professionals to overcome theirs.
Let's go back. Please, if you've got questions, just put them in chat or Q&A, but chat's fine. Let's go back to the actual healthcare workers, the frontline workers. And Taylor, I know you were saying that, a lot of, and this gets, this is not a new thing. A lot of nurses are worried about their roles being supplanted or replaced by AI. Is there truth to that, or is the work going to change? Where are humans still going to need to be situated within, care in a very, very general sense? And I guess in terms of people worried about their livelihoods within the care economy itself.
Yeah, I mean, I suspect that I don't think nurses will ever get supplanted by this technology. I mean, even just given they're just overrun in terms of the healthcare system as it is, I don't think we're ever going to not need them. But I think in pretty much every area, you almost need a human present there. And I think this feeds into trust, like Ilona was discussing, that if there's just like some machine there handing out health decisions to people, that is not going to make them happy. So, but having a person just there in the first place, I think that alleviates a lot of the concerns they have. So I suspect it's going to be more about AI assistive tools. So they're more feeding information to healthcare workers that they use that information to make the decision. So I think for the most part, it will probably shift what their role is like, though. Like they might rely more on, I don't know, like soft skills or things like that, as opposed to like thinking hard about certain decisions. But yeah, it's really hard to know. I think that, and some of the studies we're working on, where that's one of the things we're interested in seeing, like how they actually see these changes coming about and whether they do see them as threats or whether they feel like would actually help them a lot in their day-to-day jobs.
I guess in the work you're all doing, that one of the areas literally, I guess, remote locations seem to be where you've got staff shortages anyway, perhaps shortages of technologies in situ that would help with diagnostics. How much emphasis is being put on the benefits to people in regional and rural locations in the way tech's developed, and how much is the technology that is being developed factoring in the cultural context of people who don't have access to health facilities, may not be particularly health literate in some cases. I'm not trying to characterise people in rural areas in that way, but who don't have at their disposal the kind of breadth of health services that someone in a large city might have.
Was that a question to me or to?
Well, partly to you, but I suppose in the case of people on the phone line, it's already geographically neutral that people can call a line. But you know, how much more? How, you know, what are the potential? What's the potential in focusing on having, you know, almost complete coverage of certain kinds of diagnostic tools or whatever in rural areas? Does this stop people needing to go to, is there a potential through AI to stop the need for hospitals in certain areas? Is there going to be pressure on the health system to contract services because AI is seen to cover the majority of things people might have needed to come into town for before? It's just a really general question, I guess.
Yeah, I'm not sure entirely, but I assume like in terms of seeing specialists, it might increase accessibility a little bit, because rather than having to travel to a different state or drive for 3 hours, then potentially you could have an AI, I think, which could give them some information around it just wherever they live. But I suspect we might be a bit far away from that happening in reality, but yeah, I'm not sure.
All right.
Yes, so I mean, like, this is not AI, it's not on the same level, but for instance, just the telehealth was this big thing, you know, like 10 years ago, people thought it was so special, no one was using it. But COVID has taught us that when technology is there, it can help clinicians deliver treatment to regional areas. So for instance, at our clinic at the university, we run a specialized program that's for families and kids where kids have an anxiety disorder in regional areas. So you can just see when the technology is there, you can offer these services. So it'd be very fascinating to see once we're just automatically using these AI technologies, we don't even know what they will look like. It'd be wonderful if it allows people in remote areas to get better access to healthcare.
Yeah. Great. Just a couple more questions before we actually have to wrap up. From Kafil, there's a question to Ravi, Chris, and Alona. Have you thought about using large language models in research where patients' voice transcripts will be input into the models? It's a huge question, I think, especially after hearing about, you know, the potential use in the case of Lifeline. And what kind of consent would be required in order for that to take place, I guess? Ravi, do you want to have a go at that one?
I think that question feeds directly into Chris's fabulous work, actually, where he's using directly large language models to analyze patient experiences. We might say
records, but look, there's certainly people using large language models, natural language processing, looking at things like qualitative interviews and research. And it certainly has crossed my mind about how you could apply this technology to patient interactions, whether it be in healthcare, psychotherapy. It's not something I've had the chance to look at. But look, I think some of the issues around privacy is still an issue. They're getting addressed to some degree. Some of these companies are finding better ways of protecting data, but I think there's still a lot of lack of trust, even in the research community. I know that when I've got students submitting ethics proposals and utilizing just a tiny bit of large language models, and there is a lack of trust among the research community, understandably, and so that then applies to, you know, what would be patient material. Makes it a lot more difficult. But look, it's a fascinating area because so much of what we know in mental health, but also people have looked at outside of mental health to medical health settings. The interactions between a physician and a patient is so important, whether it be in decision making or the sense of trust that the patient has for a treatment. So I think there's huge potential there from a research perspective, at least.
Great, thanks. Now, I believe there's a raised hand, Stephen McKeever, who I can't see, but Stephen, are you there?
Hi, yeah, I was. It was points about following up. I'm the associate professor in nursing that's working with Taylor and Ilona on the projects in relation to various aspects of AI use in healthcare. I was picking up on the point about clinical acumen and nurses and what they use and what they don't use, and I was responding to the point essentially. And there is definitely a lack of trust, but there's also a lot of skepticism about what it's actually going to do for nursing, and how it's actually going to aid us as a profession. It's the diagnostic side of things may or may not be important, but I think where AI may be more useful is in healthcare management and being able to move beds around and where that might be useful and how that might be useful to the nursing profession itself. So just making those points.
Great, thanks. Unfortunately, I think we're actually out of time. So this is continues to be, has been, will be, I think, in future conversations. We're in fascinating discussion. Chris, Ravi, Taylor, and Ilona, thanks so much. Thanks everyone also who's taken part through asking questions. And I'm going to hand you over now to Sam to close the event. Thanks, Sam.
Well, thank you, Lawrie, and thank you, everyone. I think I speak for everyone when I say that was an absolutely fascinating discussion, and we could have gone on for many hours, I think. And happily, we'll have a chance later in the year to, I think, take a deep dive into these issues and more at an AI and Health Symposium that's being led by our colleague, Dr. Julian Oldmeadow. So lots of chances to explore this in much more detail in a couple of months' time. I want to just take a moment to thank our amazing guests as well. 5 minutes is almost a terrible injustice, isn't it? But Ravi, Ilona, Chris, and Taylor, thank you very much indeed. That was really brilliant, and I think gave us a great sense of the issues and the complexity and the nuance and just the general thoughtfulness that's being used to approach this important issue. Thank you, Lawrie Zion, for leading the discussion. It was really brilliant to unfold some of these ideas and connect some of those dots. So thank you very much for that as well. And Diane, of course, thank you very much for opening and arranging this whole session. It's been brilliant to see what's going on in the Department of Psychological Sciences. We have events coming up in the future that will explore these and other issues. So to learn more about this, please visit the Social Innovation Research Institute website at Swinburne University of Technology, or email us directly, and we'd love to continue the conversation. But for now, thank you all very much indeed for your time, and we'd love to see you again at the next Tech by Society event.